So what are the benefits to us? So big deal. Now I'm doing this for my clients. What do I get out of it? What is countertransference? Anybody? What is countertransference?
It's the feelings in us that the client's behavior or thoughts evoke in us.
Okay. What's a trigger for you? It's a trigger. Countertransference is triggered. Triggers. We get triggered. Thank you. So she was saying that countertransference is when our feelings are evoked out of whatever the client is expressing to us. It's a trigger. We get triggered. So we need to be aware of that. And when we're listening to other people's trauma, we may get triggered not only to our own trauma, but for some people in this business, maybe no one in this room, but for some people in some roles in this business, what gets triggered for them is, why do you get to have 5 days off in the hospital and I have to keep going to work? That resentment gets triggered for them because they have some trauma back there that never got dealt with. So we need to be aware of that countertransference and what it actually is. It can relieve compassion fatigue and the effects of vicarious traumatization. Compassion fatigue is when we really do get tired of hearing the stories. It's too much and we're overwhelmed. Vicarious traumatization is when we start to get symptoms of a kind of a PTSD. It really affects our spiritual outlook, our outlook on whether the world is a safe place or a place that we want to be. It's not a pathological condition, but it is something that can arise out of our work. And it can relieve this, and I'm going to tell you how. And it can also prevent. Burnout is when we want to quit our job. We're done. We want to go do something else. I don't want to do social work anymore. I want to go wait tables, whatever, or write books and not be around people. It can provide tools and prevent re-traumatization. It's measurable and can be cost effective. It reduces that revolving door cycle because it helps people break that chain and really get on to whatever their life is. It can provide structure with appropriate boundaries and protection regarding liability issues. We all have to worry about liability issues. So with the trauma-informed approach, when we recognize that that person's trauma has had an effect on them and they're having some kind of an outburst at us, we don't have to get drawn into it like it's about us. It's not about us. We can go, I learned a tool that was, sorry, we don't want them anymore. That when people were doing that on the hospital unit, the trauma treatment unit, when people were trying to personalize stuff between themselves and a therapist, we learned to say, who do I sound or look like to you today? And when we could do that with compassion, people would go, oh, my grandmother, she looked just like you. Wow, she used to do this and that, da-da-da. So we develop tools. And that helps us keep those good boundaries. You know, the number one reason that therapists lose their license is for having sex with their clients, amazingly. And these clients very often, they've been sexually abused and everything's been sexualized, and they're not to blame. And if we don't recognize what's going on for them and we get pulled into something, then we're the one that had a problem. And so it can help us keep good boundaries. So what's going to change in our settings if we use a trauma-informed approach? I've found 4 areas in particular that change. Assessment changes, diagnoses change, treatment changes, and use of medication changes. So this is Dr. Bruce Perry. He's the one I said he's a child psychiatrist and a neurobiologist. He says humans are complex creatures. While having the capacity to be humane, we also have the capacity to be cruel. Why? What determines whether a child grows up to be compassionate, thoughtful, and productive, or impulsive, aggressive, hateful, and non-productive? Is it genetic? This neurobiologist says likely not. Don't we hear everything's genetics, especially in addiction treatment more and more? It's all genetics. No, it's not all genetics. So when we're talking about assessment, just because it looks like bipolar or depression or whatever runs in a family, listen to how people learn how to be in the family. Is this a response to something? Is this a learned behavior versus a personality trait or an Axis 1 diagnosis? So I'm going to read these to you. Again, they're not easy to hear. Has anyone seen the ACE questionnaire? Several of you. Good, 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 good. Okay. So the first question is, did a parent or other adult in the household often or very often swear at you, insult you, put you down, or humiliate you, or act in a way that made you afraid that you might be physically hurt? Did a parent or other adult in the household often or very often push, grab, slap, or throw something at you? Ever hit you so hard that you had marks or were injured? Did an adult or person at least 5 years older than you ever touch or fondle you or have you touch their body in a sexual way, attempt or actually have oral, anal, or vaginal intercourse with you? Did you often or very often feel that no one in your family loved you or thought you were important or special? Your family didn't look out for each other, feel close to each other, or support each other? Did you often or very often feel that you didn't have enough to eat, had to wear dirty clothes, and had no one to protect you? Your parents were too drunk or high to take care of you, to take you to the doctor if you needed it. Were your parents ever separated or divorced? Was your mother or stepmother often or very often pushed, grabbed, slapped, or had something thrown at her, or sometimes often or very often kicked, bitten, hit with a fist, or hit with something hard, or ever repeatedly hit at least a few minutes or threatened with a gun or knife? Did you live with anyone who was a problem drinker or alcoholic or who used street drugs? Was a household member depressed or mentally ill, or did a household member attempt suicide? Did a household member go to prison? So these are, difficult questions, but asking people, were you abused? What are people going to do? They're going to say no, even after they told you all about it, right? Now, these questions are not all inclusive. These questions don't ignore the fact that men can get hit and so forth, but these are the questions they came up with. And these are the questions that when people answer them, and they found that a high percentage of people had a lot of these, and then they had all these health problems. How do you feel about these questions and about using this as an assessment tool? What do you think would change in your setting if you use this as an assessment tool? What conversations do you think you'd have with both your customer and your colleagues? Would open up a lot. So pay attention to how you can use this. There are a lot of ways to use it, and there's a lot of training going on using the ACE now. So the diagnosis. Dr. Gayle Hornstein is a professor at Mount Holyoke College, and she says something I've been saying for years, and I went, aha, I'm validated now. I can say it. In psychiatry, mental illness is a metaphor imposed on people's behavior. There aren't any physical methods of diagnosing mental illness. There's no blood test. There's no MRI. What is it based on? It's based on my education. If you're in my office, it's based on my education, my expertise, my personal experience, my lack or abundance of research in the current world, and so on and so on. We all have those. And so there's a lot of work to do. I have seen doctors change their mind. I have seen nurses change their mind. I have seen it happen. And there's a lot of work to do. I know currently of a doctor, when I first heard this, I said, well, is he like in his 80s or something? Somebody I know recently saw a doctor who says, I don't believe in PTSD. He's in his 40s. It's like, wow. So we have a lot of work to do. And yeah, it is preaching to the choir, and I hope I'm giving you some more resources and tools. And, you know, it's kind of like with anything. You know, people get together in 12-step groups because it helps people to connect and to keep on path with a certain way of life. And that's what we can do when we do these kinds of trainings. We can recognize that, oh, look, I'm thrilled to have this room filled today. I have been doing these talks in various places where I've worked to 20, maybe 30 people at a time, and people come because it sounds interesting, they're not required. And yes, the doctors and the administrators, in most cases, are not going to do it until they're required, but that's the whole point of SAMHSA. You know, it's the funding source for research and grant money. If you want some grant money, you're not going to get it from them unless you do this. So thank you for that. Next we have the subject of treatment, and we have a quote by a survivor that I was allowed to use that I want to read to you. She says, "In the system, I was taught to identify with all the labels I was given, and so I lived them all expertly. I was rewarded for being what my defined role was in these therapeutic relationships. I was punished and shamed for resisting by being labeled as difficult. I was groomed my entire life to see myself as nuts, and the grooming continued as my reality was denied and I was told that my life issues were because I was sick." Imagine being this person, an intelligent person, could be anybody you know. They go to get some help. They know what their problem is. They know it's the trauma. They know they need that help. And they're told over and over and over again, it's just because you're a bad parent. It's because you don't pray enough. It's because you're not taking your meds right. You're resistant. That is re-traumatizing. That carries on what the perpetrator said. You're just crazy. And everybody will know it. That's what the system is saying. Now, imagine this person now starts developing some real physical ailments. And some of that involves chronic pain. Now, guess what happens? That person goes to the doctor to get help. And the doctor finds out that person has a mental health file. Now what happens regarding where her pain gets blamed? Oh, it's all in your head. You're just crazy. You're just borderline. Go away. You're just med seeking. And don't get me wrong, then if they give the meds, I saw over and over and over again anxiety meds being given to people, and not once were they told these are addictive. Not once were they told, oh, but you need to start meditating and exercising and eating right. That'll help your anxiety, and just take these pills for a couple of days. No, they were given the pills week after week, month after month, sometimes year after year, depending upon how belligerent they were or weren't. So we have a lot of work to do in this field. So in 1992, Judith Herman wrote a book, Trauma and Recovery, and she came up with a 3-stage model. That was to establish safety, reconstruct the traumatic story, and restore the connection between the survivor and his or her community. This is basically what we do with any treatment approach that we have. Any evidence-based treatment approach, this is what they're doing. People need to tell their story. Now, when they want to just, again, use medication, or now, when they want to use, what is it? They're researching ecstasy, I think. A component of ecstasy, it could wipe out the brain if you take it, if you get raped and you take it the next day, that you won't even remember it. It's kind of science fiction-y, but it's a real possibility, and it has its pros and cons. But treatment as we would like to see it now would cover these areas for people. So, this is a good quote from a doctor regarding medication. This is the next area. That at Oregon Salem Hospital, when they started applying, completely saturated the whole staff with trauma-informed training, and they became trauma-informed, they quit using restraints. They quit using regular medication went down 30%, and I believe, what did it say? Seclusion and restraint were eliminated. And there was a substantial decline in the administration of involuntary or chemical seclusion or restraints. So that's what can happen when you have doctors on board, when you have administrators on board. And so again, I urge you, take this information, go look up this resource and get the whole article, and go to your superiors and say, look, this is what's happening. Found an interesting article, and again, yes, I may be preaching to the choir on some of this, but I want to just kind of remind you, and I'm not saying throw the baby out with the bathwater yet. Medication can be helpful for some people, but really these medications were designed to be used short term. And what have we all learned to say? I don't say this anymore, but we've all learned to say, oh, it's just like diabetes. You might have to take it the rest of your life, right? Baloney. It does not have to be the case when people get the real treatment. So this article says most recently 38 state attorneys won a $68.5 million settlement with the pharmaceutical titan AstraZeneca for unlawful marketing of Seroquel for unapproved use. These states also charged this company with failing to disclose the drug's harmful side effects and concealing negative information about its safety and efficacy. The company's illegal practices put our most vulnerable populations at risk, including children and older patients with dementia and other debilitating diseases. Sales of Seroquel all by itself brought in $5.3 billion in 1 year. How many patients, clients do we know on Seroquel? Tons. It's common. So this goes on to talk about all the fraud that is in the pharmaceutical world, and especially in our country where we allow it to be advertised like Pepsi, you know, and the phrase is, go ask your doctor if blah, blah, blah is right for you. Isn't the doctor the one that's supposed to be diagnosing us? So medication and the use of medication will change when we're using a trauma-informed perspective, because many of the things we see manifested, the symptoms we see manifested, are trauma responses. And if we can educate people and give them tools and help ourselves learn to tolerate those responses, then we don't have to use medication quite as much as we do, in many cases even at all. So where do we need trauma-informed care perspective? We need it everywhere. In treatment, we need it in the macro facilities such as hospitals, residential treatment. We need it from private practice to agencies to in-home, everywhere. Education, daycare to PhD. We'll get into that a little bit more, some places where school systems are actually not just, because when we talk about school systems, people usually think about, oh, we need to have more therapists for the kids to go to therapy. No, we need the teachers to learn to understand this, so that they can understand that they've got a third of their classroom not doing well and, you know, identified with ADHD or whatever. Get to know a little bit their family and see what's going on at home. And that's not to condemn the families. That's to have compassion for the families and learn to teach the children differently. On the streets, meaning police officers, in the courts, in the jails and prisons, this is happening in some places. Believe it or not, there are jails and prisons where there is like treatment and actual assessment going on of trauma. Any support settings such as behavioral supports, I don't know if Iowa still has a lot of the support agencies such as Creative Community Options and the Homestead for Autism. Progress Industries used to be one I knew of. There's several of those industries, and the folks that they have working with people who are disabled in various ways need to know about this, because those folks are getting traumatized and re-traumatized. Parenting, there are actually a lot of organizations now that are applying these principles and teaching these in their parenting skills classes. Interestingly, in the geriatric world, I found tons of statistics showing how much terrible abuse goes on in nursing homes, but not very much about trauma-informed practice happening in nursing homes yet. So if you're a geriatric worker, that's something to think about. One thing I say to people, and you'll want to go just click on this, Carla, if you want to learn about trauma-informed, just go Google it and put in the trauma-informed and any other subject you want to know about. Trauma-informed in schools, trauma-informed in the police force, trauma-informed in anything, and you'll get a ton of stuff. And this has been just for the last 5 years. This did not exist before 5 or 6 years ago, when you could find all these hits. There's millions now, and if it comes up, we'll see. But what comes up on the first page is the National Center for Traumatic Stress Studies, something like that. Well, we won't mess with that. I'll let you do that at home. Yeah. Oh, there it is. It came up. All right. So as you can see, these are the main ones that come up at first, but and does it say how many? It's 23,000. When I first started looking at this, it was, or 23 million, it was like 15,000 hits would come up. And then it started over the years, it'd be 16 million and so on and so forth. It's just amazing to me. And now I here representing my company called Trauma Informed Training. And I've created with my partner, business partner, an online CEU business where you can go and read a book and take an exam. It's all trauma-based topics. And we have a lot of competition. There are a lot of other people out there doing trauma training, and 3 years ago that didn't exist. So again, I encourage you to go look that up for yourself. So we're going to look real briefly now, what are our challenges? We were going to look at that. Where'd she go? There she is. We'll come back to Iowa. This is Dr. Sandra Bloom. She's on the East Coast. She created something called the Sanctuary Model. She has something really important to say here, because I think this gets to the gist of why is it so important for the doctors, the nurses, the administrators, our colleagues to see this and to accept it. You know, really, if what was happening like we'd like it to be happening, we could have filled up this room 5 times for 6 more days and just done this over and over again. There are enough of us to train for that. But she says training programs and degree programs, et cetera, are still woefully deficient in conveying the research data to the people who need to know it. Trauma training is not about the seemingly simple problem of giving people information. The real problem is that the material is challenging, threatening, and it may elicit resistance to change and denial within individuals and within entire systems. Why is that? Change is hard. I tell my clients, you know why change is hard? Because you're changing the neural pathways in your brain. And when you understand that, you can go with it and get the support you need. But if you don't apply that to yourself as an organization or as a head of an organization or whatever, you're going to stay in those old ruts. Challenge is our own mirrors. What do we see reflected back to us in the people that we work with? Our self-care. Yes, it's re-traumatizing to be told you need to do self-care when you're required to sit at your desk and eat your lunch. I keep saying I didn't get that class in social work. I don't do that. It's interesting. The crisis center that I worked at in Tucson was big. It was a room as long as this, lined with computers, and it was crisis counselors. And we went out in the community and we met with people who walked in on the street, and we did phone work. And the place smelled horrible because everybody ate at their desks. Even when they're just fooling around on Facebook, they ate at their desks. I'm like, why do people do this? And so another social worker my age and I, we just go to the break room, and people really didn't know what to think of it. But after a while, a couple other people here and there started to do it. And it blew my mind, because I would ask people, did you guys ever have any training on vicarious traumatization and self-care? Oh yeah, we had that training. I'm like, okay. And then I visited, one of the things I'd had to do sometimes is go out to the VA hospital and assess for emergency settings. And I'd go in to see the social worker, the brand new social worker, brand new out of school, and she's sitting in front of her desk eating out of her Tupperware bowl. I'm like, I just didn't get that class in social work, and I'm not going to do it. So our self-care is very important. I believe that if you're really trauma-informed, you're not going to be able to keep your mouth shut about it. 3 weeks ago, I went and I got a facial, and when I learned that the technician was a psychology student, I said, have you learned about trauma-informed care yet? And she goes, oh no, what's that? Well, then she gave me her story. She hadn't heard of it. She'd been in the foster care system and on, and was very accomplished, and that's why she was going into psychology. On my way up here, I sat on a plane next to someone who was a school teacher, and guess what we ended up talking about? And she, at the end of our little conversation, she said, wow, you're really making me think about things differently. I really didn't say that much, but I just can't keep my mouth shut about it. And everywhere you go, and people want to hear it. This woman was saying, yeah, we really need this in the schools. And she was saying that a lot of her kids had problems, and she took a relaxation tape to school and really helped them and so forth. So we've got to keep in mind these challenges and always be looking at our own experiences. What is your experience with challenging yourself in these ways? It's very important when we're doing this work, whatever our setting is, to have things that keep us going. They have slogans in 12-step. I know a lot of people in 12-step. I say I'm a proponent and not a born-again member. But, don't let the weather make your day. That was one somebody used to tell me all the time. Or, a preconceived expectation, or an expectation is a preconceived resentment. That's a slogan, okay. But here's some slogans that I have found that helps me keep my compassion to the fore helps me, because don't get me wrong, in my private practice I saw up to 8 people a day, back to back, for 4 days a week, and every one of my clients was a trauma person. And 2/3 of my clients had the so-called Access 2 stuff, which is what I invited into my office, right? Except that, you know, I'm a person, and so I would need to have these little things to help me remember why I'm there, why I'm doing what I'm doing. One of them is explanation, not an excuse. There, you know, maybe it's an explanation. You know, my dad got beat every Saturday night by his dad, so that's why he beats me. Okay, well, that's an explanation, but it's not an excuse for hurting children. There isn't one. And so you can have compassion for your dad, but you also get to claim your anger about what you went through. And you don't have to go be angry at him. I help people do expressive anger work and move through it and move past it. People are trying to get their needs met, or as I see it, usually or often their perceived needs met. We all have our own realities. Okay? People are always trying to get their needs met. They're not trying to annoy me. They're not trying to negatively manipulate me. They're not just trying to be needy at me. They're just trying to get their perceived needs met. When you look at things that way, you can work with that versus criticize and judge. And that's thought stopping when we do that. When we criticize and judge and write the person off, that's a thought stopping process. This to me opens doors. Okay, I understand you're trying to get this need met, and let me know how that's working for you, because you say you want this, but you're doing this. Those things aren't going to line up. How can I help you? People are doing the best they can, and they need to improve. My first couple years of being licensed, I went to four weekends of DBT. I think I have like 50 credits doing DBT training, and I like DBT a lot, though I don't think it's magic and the be-all, end-all, but I love the philosophy of it. It gave me a philosophy. So I took a couple of their statements and put it together and made a dialectic out of it. When all I do is tell a client, oh, poor you, you've been victimized, you're doing the best you can. We could be in therapy for 10 or 15 years, which I don't think is necessary in most cases. If all I do is, you need to be better, they're not going to come back the second time if they even sit through the first session, right? If I put that together, you're doing the best you can, and you need to improve. It's a dialectic. It makes two things that look like they're opposite come together and become something that you can work with. So you can give yourself credit for what you are doing, and you can challenge yourself to do something else. This is my very favorite one, brought to me by clients in the inpatient trauma treatment program where I trained. The day came when the desire to remain the same was more painful than the risk to grow. Anybody that ends up in your office, whatever that setting is, they're in a situation where they've been in pain, and now their pain is driving them to do something different than what they did before. And they're going to do that over and over and over again in their course of treatment or recovery or whatever it happens to be that they're doing with you. And that's the point at which they have to get. That's the point at which we get growth. And we've got to let them know that we're there with them in that. So I've come up with what I call trauma-informed ethics. And you all have a copy of this in your slides. And I'm always looking for feedback on these. Something can be added or taken away. I certainly will consider your viewpoint. I will strive to apply compassion in all my relationships, to be aware of my trauma-related issues, to establish an environment of safety, physical, mental, emotional, and spiritual, to the best of my ability. I was always, you know, trauma people, they come in and, can you guarantee me I'm going to be safe here? And I would say, I don't know if a rock's going to fall out of the sky. I can't do anything about that, but otherwise, the best that this little old lady could hold all that stuff off, yes, I will. So you teach them balance by that. You work in balance, including balance in your own self-care, and to offer hope, focusing on strengths while offering practical tools for improvement. I will strive for balance and boundaries, respecting that those I serve need my support, but also need reassurance that they are capable. Early on, after a lot of DBT training, I created a little check-in process by voicemail that I allow for my clients. If they're having a hard time, they can call and tell me in 2 sentences what's going on, then tell me what coping skills they've tried, then tell me which ones they're going to try next, and there's no end to coping skills. Either you keep trying until something changes, or you fall asleep because you're tired. So it becomes a learning experience, and I got with the high level of complex PTSD folks I served, I got very few after-hours calls. I never had to rush to the ER and meet somebody there. I never went to somebody's house. I didn't have to. I have never had anyone suicide. That's just luck and some of this, but you know, those things can happen. I'll strive for the ability to treat with respect those I serve and those with whom I serve. I personally have had to learn, like I said, to be respectful and cordial of people I didn't have a lot of respect for professionally, but at least in my interactions with them at work, I had to be respectful, but that did not mean I shut my mouth. I learned to speak tactfully and to say my opinion in the face of doctors, including military corporals and generals who I did not agree with in a couple of cases, and I sat there and said, no, I don't think it's that, I think it's this. I learned to do that. Not that I'm always taken seriously, but I don't shrink back now. But neither am I in your face about it. I will strive to keep up to date with developments in the trauma-informed field, but refrain from holding any one method or modality as the only or right way. And I'll strive to offer education, support, practical tools, and resources. So I hope those are useful to you. And we're going to move right on into the second session. We've got about 45 minutes to cover complex PTSD and two very important concepts. If you need to run to take a break or whatever, feel free. I have that much information to share. It should be as people come and go. So this session is complex PTSD and two essential elements. Has anybody in their settings and in their work heard the term complex PTSD used a lot? Private practice, yes. Okay. Anybody else? Complex PTSD? Okay. How about borderline personality disorder? Okay. How's that seen in your settings? I would love to hear from somebody about how that's seen in your settings.